Hello and good evening, everybody. Welcome back. For those of you that watch part one of our full mouth rehabilitation or full, this is the second part that we're going into. If you haven't watched it, please let us know, and we can give you access to the webinar from last week. Again, I just want to go over a few things. I'm sorry for people that have heard this before, but for anybody new joining, just wanted to talk about a couple of things that are up and coming, and so that we can, anybody who wants to join us in a number of things that we're doing in the new year, show you the availability. I'm just going to go share my screen with you. So as I said last week, we're introducing a boot camp next year for people who want to introduce implants into their practice, or for people who are placing implants and want to know more about it in a sort of concise 2-day program. There'll be lots of demo on the actual surgical part of it, typodont, and we'll be going through everything from selecting patients, patient assessment, note writing, medical legal, so that you do things in a manner that you are protected, gaining consent, informed consent, and how to do that properly with guidelines, not just signing a consent form. It will also include then treatment planning and basically how to basically create your osteotomies and drilling protocols, and restoration, and we'll also be dealing with some complications. That is on the 5th and 6th of February next year on a weekend. It's $595 for one person and the same for two. So if you bring a buddy, it's basically half the price, and that's 12 hours CPD you'll be getting for that as well. For all inquiries, please contact us at hello@drbobbychhoker.com.au, or feel free to give us a ring on 0280709010, and you want to address your email or your inquiry to Millie, who is basically the course coordinator. We also have a section for dentists on the website now for you, for anything up and coming or anything of interest. So along with that, please follow us on Facebook and Instagram, and if you can share any of the ads and things we've put out for webinars and things that we're doing, that would be great. We're trying to create a community. So part two. So treatment planning of the mandible, we're going to go to. In the lower, the transition line is not as influential because of the drape of the lower lip. And the top is more important because when people smile, the upper lip raises and you can see where the bridge is starting. And ultimately, this is very important. You don't want this to be seen. So you need to plan this properly. We're going to go into some of the planning. The low tooth level is very important because loss of posterior support causes splaying of the anterior teeth, and you get alveolar compensation where the teeth anterior are higher than others. So alveolectomy usually on the lower is essential, even though your transition line may be covered by the drape of the lower lip. A couple of things that you do need to basics. We're going through basics, and on our certification diploma and MSc, depending on which one you want to do, all three, we do go into the whole thing in very much a lot of detail with some recorded surgery, but we also have people come in and assist in live surgeries that can actually learn the process one-to-one. You need to look for the mental nerve, and just as importantly, other than the ID level, though that doesn't interfere as much because we're planning and placing in the anterior region, is the loop. And quite often people miss this or don't look for it. There is a way of looking at it radiographically, and you need to identify it and locate it exactly. I don't suggest that you do this type of surgery without knowing how to basically reveal and expose the mental foramen, find the mental nerve, and know exactly where it is. There are also techniques where you can use probing and other things to check the anterior loop with a graded probe, so you can see exactly how far forward it goes, because although CBCTs are great and they're very accurate, there's nothing like investigating it for yourself. If you're going to be doing this type of treatment, you don't want to be placing you don't want to be placing blindly. So you just need to have a look at that. Sorry, I just want to see if there's any problem. Somebody's asking about lingual fossa. I'll get back to that. We do identify lingual fossa. We also identify the internal lingual ridge as well. Quite often, the main area at the lower that I'm mainly concerned about is not so much that, because if you've done your planning, then you will be able to see most of these things, is the lingual artery, particularly in cases where you've had resorption, teeth being missing while at that anterior region. You'll find with the mental nerve and the lingual artery that they tend to come up onto the surface. So when you're making that decision, you need to be careful. And especially with severely resolved ridges, we tend to make the horizontal crestal incision more buckle and come backwards, because that blood vessel comes to the top. And posteriorly or towards the premolar region, you'll find the mental nerve will have, because of resorption, be on top of the ridge, so you don't want to go through that. The mental nerve, the anterior loop, can be somewhere between 5 and 7 millimeters, which significantly affects your placement, because although that the mental nerve is the feature, or the vital feature that determines where you're going to place that angulated implant, and because that will determine the angulated implant. If it's placed an angulation more mesally, you're then going to get emergence of the implant more mesily, and you need to consider that wherever that comes out. For example, if it comes out around about the first premolar region, you're then going to end up with quite a long cantilever if you're trying to replace teeth up to the first molar. You can't really, as I said before, rely on CT and guides. CT will give you a really good assessment, and you must use that as a diagnostic tool and create notes on it. I encourage you not to just look at it and then plan in your head. You need to write these things out, and part of your surgical protocol should be to have this, you have the section that you need, almost like an OPG section, and you should be marking out teeth that you're going to be extracting. You have a lectomy line, and where you plan to place the implants and which angle and what landmarks you're doing to do that. There are guides also that you can use that. You can make a small osteotomy in the midline, a very small one, sort of 1.5 mil, and use a pin that has a curved guide that allows you to help with angulation. But I find that this is great. However, this isn't always useful, and you need to be able to plan and look at the case individually. You can't just use a set route. CT guides, guides, I've seen a lot of, and I've tried a number of them, and we continue to try them in a very safe manner, just as a guide to see where they're going and what we would have done had we used the guide. And you get stackable guides now and everything else. You cannot completely rely on the guide. It's a guide, okay? And my very strong suggestion for this is you need to know how to do this without a guide, because guides aren't always accurate. Guides aren't always where you want to place the implant, and guides can break, guides can be inaccurate. So you don't want to blindly rely on that. Okay. So looking at the case, I like to see, when patients come in, we tend to forget, we look at the mouth and we jump in and have a look at things. And, looking at the mouth as it is, you want to see what you can see, not going straight to low, because that's where we're doing surgery, but you can see that, there's a fair bit of wear here, considering that the patient hasn't got any upper teeth anymore, wearing a denture. Whether it's pre-denture, we don't know, but, there's a certain level of parafunction going on. The patient's oral hygiene is not to the standard of placement of implants, so you would need to basically get the patient healthy and rid of any periodontal condition, so that, and have them motivated, because you're going to be placing a fixed prosthesis, and you need to make sure that they're not going to end up in the same situation that they started in because not able to clean it. And we have quite a strict regimen and a certain number of appointments before we even have any treatment, and we have assessments, and patients know that if they're not able to do that, if they get to a decent standard, whilst they have a provisional bridge, we will assess that prior to coming to the final bridge. And in the consent and in our discussions, we talk to them on the basis that they may be better off with a fixed removable appliances in the form of a precision fit denture that's shaped like a bridge, because if you've got 4 implants, you can do that. You don't really need flanges or anything else. Also, as you see here, you can see some darkened areas have gone through to the dentine layer. There's no posterior support. But more importantly here is knowing where your transition line is going to be. Because when the patient's smiling like this, you need to know that you're going to be 5 millimeters is what we take as a standard above the smile line. And the reason this is also important, usually we try to go to 16 millimeters, 17 millimeters from the tip of the tooth or planned tooth to the fixture, the implant. So you need to determine in someone who's dentures exactly where the transition line is, because with people with teeth, you can use a teeth as a marker and plan upwards from there. From this, it's more difficult, not completely impossible. You can use putty indexes. Some people use a clear denture or a clear trough guide prior to doing the alveolectomy. I encourage that to be done or planned way before, not at the time of surgery, because your battle is between how much bone is left for you to place implants versus a transition line. Now, if the patient has a very high lip line and not much bone there or bony height, and you're left with very little height, then this is not probably the way forward. In those situations, you would think about alternative measures. If you're not going to go straight to fixture because you don't have sufficient soft tissue in the area and you're going to end up with very long teeth, then considering an implant-based denture is not a bad option. Here you can see pretty much the situation with the upper, loss of posterior support. Again, you can see the level of oral hygiene. Below the tissue, just as a guess on this one, because I don't remember, I would say that, the bone's probably, 3 to 4 millimeters below that soft tissue, and that drape of the lip to the soft tissue is probably at least 3 to 4 millimeters. So it's unlikely that you have to do an alveolectomy in this, but you need to determine that and see that you've done the working for it. There you see from that side. Also, this is important because you want to see where your alveolectomy line is. It's not just anterior. Patient smile, you can see up to the premolar and molar region, so you need to make sure your alveolectomy is also planned in that region. So, you want to take the upper anterior region and then the 2 sections either side, the left and right, and there may be different levels of alveolectomy. You don't want to destroy and remove healthy bone because that's precious to us. Again, on the other side, the same. Here, the bone is probably low because of that retained root and maintained bone in that area. Moving forward. With patients without teeth for years, video rarely lost as they have compensated over time. However, if over-closed, open it minimally. Have a more closed video than an over-opened one. Teeth interference occurs with jaw pain and opening fatigue. So, you need to see how much you're going to increase the vertical dimension. A patient has over-erupted teeth with alveolar compensation. Maxillary incisal edge is in the wrong position with excess of bone in anterior area of the mandible and maxilla, which we can make use of. Plan by marking the alveolectomy, the incisal edge on study models, or ideally on your scan, if you use a scanner, and your CT. Occlusal rims to evaluate occlusal plane, vertical dimensional, centric relation, teeth shade and shape, smile line, midline, canine, and lip support. People ask me what I try and restore to. I'm from the school of sort of like Hankey and Dawson. I try and restore back to centric relation, and you just need to know how to be able to get the patient into centric relation consistently and accurately, and also know how to measure that. So the transitional phase, primary stability and surgical technique, cross-arch stabilization, implant surface, implant design, and advantages of immediate loading. So primary stability surgical technique is under preparation of the osteotomy, basically, and quite often in these cases where you have lots of teeth that are mobile and sockets, you have less sort of stability of the implant going through, because you're going through sockets, but in most cases, largely the part of the implant is in fresh bone. You want to determine the type of implant you want to use. We're using an external internal connection. I mainly use internal now. It's click fit. It's far more accurate for me. There's a lot less fiddling, and it has very good outcomes. And you want to know about the implant length and bone to implant contact. The more you can get, obviously, the better. I don't place implants all the way up to the nose, because the older way was to basically, as it says, bicortical fixation. So we would basically penetrate the nasal floor. The reason I don't do that, because there's no need for it. And secondly, if you have a problem where the implant fails or there's a complication with it, you then have bone that you can utilize by using a longer and or wider implant. And you need to see how much cancellous versus cortical bone we have, and the importance of both in that situation. Bicortical fixation is fixation at the at both top and bottom. So here you see in these cases, I've almost gone up to the nose. This is an older case, the way that I used to do things. In the low, we have plenty of bones, long implants. I think from looking at them, there's 16s in the middle and 18s distally. This is somebody with a provisional prosthesis, and you can see the multi-units there. We've got the two upper implants anterior to the sinus, and the lower implants anterior to the ventral nerve. This patient had a loop both sides, so that's why they're more anterior than the OPG suggests. Cross-arch stabilization. This is important. This is the difference when people don't have an understanding of all-on-4, and they think, like, how can you just immediately load this thing and put a whole jaw of teeth on implants? Obviously, there's some theory involved, and you need to know that theory, because you do one thing wrong and the whole thing unfortunately comes falling down. That's the unfortunate thing about using this technique. But we had a patient who had a consult, for example, and there's one things I'm not encouraging. The forming community, want to form a community that supports each other. And this is something I frown upon very much, is basically throwing other dentists on the bus when you don't know anything about it. We had a patient who's recently just come back to us, and it doesn't bode well for you. People tend to do that to try and get patients into their book and do what they're suggesting. Well, you're going to be held accountable, and if that doesn't work or it's not the right way to go, the patient knows that conversation. And although whatever you say has to be written down, otherwise it didn't happen, from a patient's perspective, legally and otherwise, whatever they say happens because they've only dealt with you and you've dealt with many patients. But we had a dentist just basically slating our treatment plan and putting it down and saying we didn't know anything about it. And I hadn't seen this patient in, I think, a year. They hadn't done anything. And they'd come back, and I looked at the CBCT again today, and for me, it's definitely the right treatment plan. The alternative of, if they wanted fixed prosthesis, of taking the teeth out and grafting and come back a denture for 6 months and then placing implants and then restoring, is risky because they have a fair bit of bone loss. Most of it is vertical, yet they still have decent bone in the anterior region. And for people that tuned in last time, we talked about the Bedrosian scale and how to use that and to determine whether you're going to straight to fixture, or you're going to all-on-4, you're going zygomatic, or you're doing denture-based, implant-based dentures. They can withstand within 50 to 100 microns of micromotion, beyond which fibrous encapsulation occurs, and that's what you don't want. Okay, load is important, hence good spread. Occlusion, you've got to check the working side, non-working side, premature contacts, excursions, and cantilevers. Cantilevers, we try not to exceed 14 millimeters. That's the sort of scientifically proven limit. We usually try to stay within that, well within that. Implant surface and design is also important. Machined and SLA, a lot of the implants are now looking quite similar. So they tend to have a tapered profile because every time you turn the implant, it's engaging new bone because it's becoming wider, hence having more contact and better stability. Okay, and we all know, and if you don't know, primary stability is king or queen, as if you want to see it. The machined surface they tend to do now towards the neck of the implant and SLA or aggressive SLA towards the rest of the implant. The reason for this is the machine part, if it's machined and it's finer, the surface is not hyperporous, so you're not, you need that further down for bone to go into for it to integrate. The reason they do this at the top is a number of things. You're getting less likelihood of peri-implantitis, because if that surface becomes exposed in some of these implants, if there's no pocketing and it's sub gingival and there's no actual connection to it, it can survive very well. Alternatively, in these situations, it's very easy to remove that surface and polish it. So you're moving the implant down in effect by taking off the top of the surface. And laser lock is another thing that a lot of companies use, where you're getting hemidesmosomal attachment at the top of the implant to the implant. Okay. Tapered as discussed, aggressive. So a lot of these, as they taper, they also have an aggressive ferrule or thread, which is wide and sharp to aggressively grab bone. I'm not over aggressively, but I'm just talking on that level of basically be able to get that primary stability, because one of the things that you need here is that you need to have a minimum of, they say 25, but my strong recommendation is minimum of 35 Newton centimeters on every single implant. You can't have 3 and then have the other 3 support the other one. If you have one that doesn't talk to that level, and there's multiple techniques for doing this, you do not immediately load. You go to denture and have a stage 2 to expose the implants when they're integrated, and then go to provisional, then finalized hybrid prosthesis. And they have non-cutting tip, especially when we're using it to break into sort of the base of the nose. Increase the surface area with the bony osteotomy, enhances the initial stability of the fibrin matrix, accelerates osseointegration by osteoconductive properties. The angle implants obviously having, a much, other than bicortical fixation, having a lot more of the implant in contact with bones. So you've got increasing the surface area. Immediate aesthetics, advantage of immediate aesthetics from having no or bad teeth. Obviously, again, you need to assess the oral hygiene, because that can be a negative too. Phonetics, instantly talking, not dealing with a denture or lack of teeth. Confidence for sure. You're transforming these people having no smile, no teeth, and being in a situation where things are not very nice, to having teeth, and that in itself is amazing for the patient. Comfort, as well, as opposed to wearing a denture, or going through the long route of wearing a denture, grafting, then implants, and taking 9-10 months before they get the teeth. Also find that most of my patients after implant treatment don't actually complain of pain. There's swelling, sometimes there's bruising, but a lot of them don't complain of pain. They are on analgesics and other things, but if they're in severe pain, trust me, these would not control it. A lot of the time they feel a lot better because they're being rid of disease. Aftercare and maintenance is very important. There needs to be strict protocols for you following up patients to make sure that that is covered. The aftercare being what they do, maintenance what you do with them. The chair time is less for the patient in particular, not for you. Okay. And I wouldn't go into this on the basis of the fact that this is the sort of fee for it's just going to be great because we're making this. I wouldn't do it on a monthly basis. You shouldn't be doing any dentistry on that basis. I understand we have to run a business. I understand this opportunity, but I would make more from placing 4 individual implants than I would do from doing 1 or 4. But at my stage, it's also is as expected of me. I am able to do it, I think, which is my opinion. So pinch of salt fairly well. And it's something that I think should be an option for patients. But if you're doing it because you just see the dollar signs, you'll find the outgoings are huge, and the complications and risks you have to deal with. More successful than graft and place protocols, because the grafting is somewhat unpredictable. And as we know, increase in vertical height in grafting, is only really been documented, scientifically proven to be predictable through distraction osteogenesis, and patient acceptance that's very high. Okay, surgical protocols. This is just drills. Those I think are BioHorizon ones, and there's drill sequences. This is sort of a huge part of the procedure and is really the crux of everything. And there's way too much for us to be talking through that. I can go through basic breathing protocols, but what I have to do if is a bigger conversation, and we discuss that at our courses. Also, if you want to come in, you have access to that, and you can see what I do when I'm doing full mouth rehabilitation, which is what I prefer to call it, and I suggest you call it that. I think our Prodental Council sort of frown a little bit on you using terms like all on four. Okay, so basic anterior posterior spread. There's the limit for the cantilever talking about, the posterior line and the anterior line. In that case, basically because of the cantilever, and we haven't got a good spread, so you want to try and spread the load across the entire area. It's a bit like putting all four legs on one side of the table. It's not really going to stand in that manner. And as we know, the forces increase as you get further back because you're getting closer to the hinge. Where you put a nut and a nutcracker near the hinge, that's where the greatest forces are. So in this one, you want distal extensions, possibly with short implants if there isn't sufficient bone there. And this should be part of your planning, to see that you're probably going to need to do this and know exactly where you're going to place those, because usually bone is scarce in that back area. Same in this case. In this case, you can see there's a lot of grafting that's gone on there. Largely autogenous, probably sockets. We also tend to use anything we collected from alveolectomies, and whether through rongeurs or using alveolectomy, where we have a system we use for collecting that bone, and we mill the bone we have collected, and that's all the grafting there. If I just place the 4 implants as they are, the white healing caps, the spread isn't terrible, but it's not particularly great anteriorly. And there's quite a large load from those front to anterior implants. The spacing between them is quite large. There you see them with the multi-units. We'll go into multi-units in a moment. And you can see the alveolectomy is not heavy, it's just what you actually need. You can see all those sockets and the thinning around the buccal plates, and that's where we've used that excess bone because it's precious. The standard protocols say you need 1 millimeter of barrel of bone around the implant. I always suggest at least 2. In this case, the reason I couldn't place at the laterals because there was insufficient bone, so I had to place centrally. And the knock-on effect of that has been where we've placed the very distal implants and found that the gap is very long between the anterior and the most posterior implants. I think we didn't place in the canines because that was the ideal area because of pathology and buccal defects, and it was going to complicate the matter. So putting 2 implants close together towards the back to support that was going to be the best way forward. And there you have it sutured up. Okay, whatever you want to call it, teeth express is something that is term for that BioHorizons use, we use all on 4, there's teeth in a day, etc. I now exclusively use Straumann implants because they're the ones I find for me, and you have to find out what's best for you, but personally I feel they're the best for me for the procedures I do. I have used a lot of BioHorizon implants, also a wonderful implant. I still place for some referrers, and in some cases I still use a BioHorizon. They have the laser technology. They have optimized buttress threads as well. They basically engineered for superior stability and for accepting an immediate load. And they allow for faster osseointegration. And they have the laser lock, as we discussed, and intelligent component design for restorative flexibility. So it's reliable and predictable and efficient workflow that minimize chair time, maximizes profitability for the practice. There's obviously a business element. There's placement of the implants, placement of the multi-units, placing titanium copings, creating a provisional denture, and immediately loading. I don't tend to go the way of a provisional denture and placing copings anymore. We are completely 100% digital. That again is another conversation that's quite complex. Subject matter in itself. You need to know exactly what you do. It's not just sticking some impression scan bodies on and scanning. There's a very specific technique, and you need to know what to do and what not to do, because it's very easy for that to go wrong. And your ultimate goal is to have a prosthesis that's passive. You know, there's no tension. If you're having to screw certain screws to get it fixed, that means it's not passive. And that lack of passivity will pass through into the bar or the actual superstructure, the prosthesis, and be transmitted to the implant, so they're in tension. This is one using BioHorizon implants. So going through this. This is courtesy of BioHorizon and Dr. Lewis Cummings. So clinical images will just go through and show you exactly what is happening. Okay. They take a blue mousse impression printer in the denture to capture the implant placement, and I'll show you what actually goes on. So the denture, the implants are placed, you have the multi-units and the cylinders. You then need to make holes in the dentures for the cylinders to pop through. You'll then want to cut the heads off the cylinders so that it's flat to that surface, because you'll want it to occlude with the opposing arch. Even if you're treating the opposing arch, you want the two prostheses to occlude to each other. That hole around the actual cylinder is filled in a number of things that people use. Some people use Duralay, some people will use structure, and sometimes people will use cold cure. A lot of the time when people use cold cure, they won't send this then to the lab. They'll actually finish it up in-house, not sort of the way that I would like to do it. I prefer to have incur the lab fee and to have it finished properly. There's your denture with the holes ready for the pickup of titanium copings. Titanium copings are prosthetic screws from the multi-unit system. Okay. There they've been placed, and now they've basically put a rubber dam over the copings, lacquering the acrylic placed around the copings. So you're fixing them into place. The denture is placed over the copings and the acrylic allowed to harden. In this situation, you obviously want the copings to be accessible, because you've got to unscrew the prosthesis or the denture, and your temporary. So usually what we'll use is something, we use a few things that stick out from the coping sticking out. I think there's a couple of implant systems that do this, so that once that's actually set around them, you can pull that out and it's created a channel to the screw hole. There's the prosthetic screws are removed and copings picked up in the denture. I've never got it that neat, okay, but what you basically want is for the denture, the copings to be fixed into the denture without any form of movement, because if one moves, then it's not going to fit. Quite often in these cases, we will use some form of wash when we used to do it this way, and replace it so that we get the fit surface accurately too, because you'll find that putting whatever you're putting in the acrylic structure, everything else doesn't actually, because it's somewhat hydrophobic, won't actually give you a complete seal like that. Okay, lab technician moves it, says acrylic fills voids in denture. In our case, when we have the structure and the wash, we send it to the lab. They'll mount the model properly on analogs, and then remove everything you've put in there and replace it with acrylic and polish it and make it look wonderful, so that you can then place it. And that's a provisional prosthesis, which is ready for placement. And there you have an upper and lower, well, the upper provisional prosthesis, all right. After it's been, that's a definitive provisional. So, you can have basically a CAD/CAM mill substructure or monolithic zirconia, which is all straight to, without bar, directly to the multi-units, whereas the CAD/CAM mill substructure has a titanium bar. You can also now have a mill substructure or monolithic zirconia as well, if you please, and now you also can have individualized teeth. Okay, so multi-units, they're available in a number of sizes and angles. They're low profile for the sculpted design. The abutment motion profile seats easily in deep tissue and provides optimal soft tissue contouring, and that's what you're looking for. You need to sort of have a look that you're placing multi-units. Usually at the time of surgery, I'll place them just mildly subgingival, because by the time that tissue settles and you've had some bone resorption and you get nice tough keratinized tissue, there's no inflammation, and you get anastomosis of the flap, you'll find that you get shrinkage of the tissue. They have 45 degrees, these ones conical connection. There's multiple different connections that you can get. There's a wide range of diameters and heights. There's one piece designed for installation, easy improved alignment, and passive prosthetic fit from the 45-degree self-centering cone. Okay, that's the BioRise one. The ones I use from Straumann do exactly the same thing. I equally like those. Okay, so they come in various heights: 1, 2, 3, 4, and 5 millimeter. Again, you need to think about, I've never encountered the tissue being as deep as 5 millimeters for that use. You can get this, and it tends to be more posterior, but if I angulate the implants, I'm not going to be using a straight multi-unit like this. But in certain cases where you don't angulate and you're placing straight implants and that tissue at the back is extremely thick, then this is the way forward. Okay, they have a cover cap, which you can then use afterwards to cover your multi-unit. As a healing cap, they're color-coded. All of them tend to be color-coded, regardless of which company you're from. And that's a straight multi-unit abutment. Now, as with all implant, well, most implant companies, particularly Straumann as well, regardless of the actual implant diameter, the implant platform diameter varies, but the prosthetic cone stays the same. So you can see it's 4.5 millimeters. So if you're in a situation, for example, where I've placed an implant, I don't have any additional bone at the end of the implant to drive it further, to engage it and to get stability. And then my next option is to go to a wider implant. I know that I can restore it with the others with the same prosthetic cone. So what multi-units do you get? The angulation is correct to using angled multi-unit abutment to redirect the screw and access hole. So rather than having angulated implants pointing straight backwards at the back, difficult to get on and everything else, that's why the 30 degrees and 17 are used. So where you have angulated implants at the back and you're ideally aiming for 30 degrees, the 30 degrees angulated multi-unit will correct that angle so that you have the same path of the insertion as the anterior straight implants. 17s tend to use where we've had to place at less of an angle posteriorly, but not very often. More often, I use the 17s at the front. So if you've got a profile of bone that points forwards and you can't place vertically up, and it means that if you put straight multi-units on there, that's still half of your cylinders or your screw hole, it's going to be coming out buckly. So what we use is 17 to tuck that back in behind the teeth, so the access hole is behind the teeth of your prosthesis, as you see it up there on the picture. And again, wide range of diameter, heights, and angulation correction. You want to make sure that it's not submerged as angulated implants. There's a lot of talk about the distal part of the implant and the multi-unit of getting pocketing, etc. If you're placing it at the right level and you're assessing the case properly, that should be the case. And you need to use the right prosthetic so that that stays gingival height, and then you're not really having that problem at all. And a wide variety of side conditions. Again, these come in different heights. I usually, in most cases, we tend to use the lower ones anteriorly and the slightly higher ones posteriorly, but not as essentially to the depth that they're saying. So you've got the angled multi-unit abutment and screw, color-coded again, and again, it's a cover cap. Okay, so the thing I like about the Straumann ones is that they have, if you look on the picture to the right, it has a handle that goes on top. And what this does is when you helps place it, because you've got to click it into the right position. And obviously it has different angles, because if you're using a hex, it's got, you know, the different facets of the hex are the angles you can get. But it allows you to see the inclination of it. So you can see that it's pointing straight down because the handle's almost extension of the top of the multi-unit, and that you can unscrew. With the BioHorizon ones, which that was probably my only niggle, was the fact that you had to remove, I found it was easier to remove that handle and then screw down because of the spacing and design of it. But the Straumann ones I use now, I leave the handle in place and screw all the way down and then remove the handle, mainly because I want to make sure it's located and it hasn't turned at the last minute and it hasn't noticed. I haven't noticed, and this is just a safety protocol. They're the hex adapters that you need for the, a lot of the implant multi-units have a different adapter to place the straight ones, and then they have the screwdriver that you'd use, whether it's in, whether using hand or not, handheld or not, that screw the angled multi-units like I showed before. I like the fact that with the Straumann ones that they basically, you can use a screwdriver to place the anterior and the posterior ones. I like the fact that they click into place, so you can actually firmly feel them click into place. We do use certain techniques to make sure that they're in the right place, that they're down, and also radiography is of use there as well. So there it's got a bit about the different implants and the number of implants and that they use for this technique. The controversy of 4 implants is basically based on Franceschi. So the 4 implants, maxilla mandible immediately loaded, posterior is tilted, anterior is axial loaded, 48 hours, less than 48 hours, and then followed up 60 months later. Measured bone loss and found no loss in tilted versus axial maxilla and versus mandible. So there you have it in terms of the study. Fracture, and this is a Marlowe study, no fracture of components, excessive forces from non-balanced occlusional parafunction causing screw loosening only, which is great. That's the use of the multi-units. You're transmitting the forces there. Something goes wrong, you get loose multi-unit, you don't get forces onto the implant, cause the implant to fail, or you lose bone crestally. Okay, stress concentration, that's Crackino et al. It's cross-arch stabilization, causing minimizing of micromotion, because you don't want micromotions. This is a good study. Worried that there'll be high stress concentration, bending forces, and greater moments. Found no difference with the implant in tilted versus axial because of cross-arch stabilization. Rigid bar to connect implants and stop them from moving, only micromotion that is negligible and does not affect osseointegration. I want to just come on to one last thing before we end. A lot of clinicians placing 6 because 6 is better than 4. That's not the case. If you look at a number of studies, you'll find that if you place 6 implants, and the only reason we didn't place 6 implants where I did that other case was to the anterior posterior spread. But in case you place 6 implants, you'll find that the implants towards the middle of the center, usually if you place 6 implants, you have no loading and aren't doing anything. And it's not cases more is better. You just need to place the appropriate implants to meet the occlusal load, depending on that case and the bone quantity, quality, angles, everything else. It's a multitude of things. Because more isn't always better. You're being more invasive. There are more things can go wrong. There are 6 implants you're dealing with as opposed to 4. So, I've been doing this a very long time, and I'd be happy to stand up for that. Okay, bear with me. I'm going to just come out and stop sharing. I think we have another question to answer. Okay, there are those who say that guided methods are for starters as they are quick and healing quick and no invasive surgery. What do you think? My job is to basically look after you, not implant companies. Okay, that's proposed because implant companies want you to use implants and buy their implants and buy components, because this is very lucrative for them, because you'll find out what the outgoings are, and they're ridiculous, they're huge. Okay, I don't believe with that. I teach this all the time. I've been teaching this for a number of years, and I find that guides are when students fall into really big problems. Okay, you can use a guide to show you where you could possibly have wanted it, where the guide is telling you to place it once and where you would have placed it. So when we teach the students, if we get a guide and they want to use a guide, I will initially ask them to have a look at where they think the implant should be placed, the angulation, etc. They could even make the finest osteotomy with a pin drill, like a 1 mil pin drill, okay, or a super extended burr, okay, obviously in a surgical handpiece, and then to put the guide over it and see if they coincide, and then have a look at the guide and see where the guide was going to be placed and whether they agree with that. Ultimately, it's a guide. When you're placing implants of that length, 3 to 4, maybe 5 degrees of error, which is very easy, because if you look at 5 degrees, if you had 2 implants on an X-ray, 5 degrees difference in angulation, I sort of flashed one and the other, you probably wouldn't notice the difference. Okay, you think they were the same. That translates at the end of implant, by about at least 10 millimeters. Okay, depending on the length of the implant, because that 5 degrees, as you get further and further up, is then translated in that, and that can cause you quite a few problems if you're going into the wrong spot. If you want to do this, first of all, the full mouth rehabilitation is not for any form of beginner. I think you should be placing implants for a while, at least a few years before you attempt this, and that's to keep you safe. If you want to go ahead to do what you want to do, then on your head, so be it. I also believe there are, when I give the course on full mouth rehabilitation, there are at the beginning, before when people come in, etc. Look, you can learn about it, so you know about it and progress your skills to that level. But there are 30 procedures that I say that you should be able to do, not not actually with the eyes closed, but actually, literally with the eyes closed. You should know those procedures really well. Okay, because those things are what you do to get the case back on track if it's not on track, and also how to deal with complications. Do not place implants blindly. These videos you see of a ridge without teeth and a edentulous patient, and they just put a guide in it, poke holes through it. They're few and far between, and they have their own errors, of what you're doing. It's far better. You're the best thing in the practice. You're the best tool in the practice. It's better to learn properly, so that that you feel confident going in. If anything occurs, you can deal with it. It's not a big deal, because your road is wide. So anything goes wrong, it only narrows a bit. With a guide, you're walking on a tightrope. Something goes wrong, it goes drastically wrong. And a guide will not save you. Okay, just because you're using guide and you present it legally and say, well, I used a guide and it was things that, so, how much did the guide expand? How accurate did you know it was? Did you verify the guide? How did you verify a guide? Who planned it? Okay, were they authorized to plan that? And you find with all the companies and guides, when you get a guide, they sign off saying that their entire liability lies with you. Look at the small print. When you sign up to each one, they say that it all lies with you. So don't go beginner guided. Not a good idea. I strongly recommend you don't. If you want to learn to do it, how to do it properly, I'm not saying you have to do one of our courses. It'd be great if you did. I think that's a proper way of learning course. Doesn't have to be ours. With a number of other courses, that's a better way of doing it. If you want to see what's involved, so you can get a scope of what's going on, when students come in and I'm doing a procedure like this, I talk through the whole thing like a teaching thing, so they can hear what I'm thinking. And that's a great way of sort of starting to learn, because you'll only know how little you know once you start to get involved, and then you'll realize it's a much bigger subject matter than I can present very quickly here. But I hope that answers your question. Sorry, there wasn't a name to that. It says anonymous attendee. But if you have further questions, please feel free to contact me. And if you need help starting up and you want to get some pointers or know what to do, or you want to come and watch a number of procedures so you can get on track and do something, then I can also talk to you about your scope and keeping you safe, and your SAT profile, and see what you should or shouldn't be doing, or what you need to do to get to that stage. So it's not about you not doing it, it's just doing it safely. I hope everybody enjoyed webinar 2 in the format for rehabilitation 4-part series. I look forward to seeing you next week. Everybody take care, and I will see you soon.